So today we're going to be talking about mutual support groups. Mutual support groups are groups of peers who share a common problem, such as addiction, and then that way they're able to offer support to one another. There's a wide range that exists today. This format really initially started with AA, but then is branched out for other needs and other formats. Thank you. Can I read my clicker? So just a little history of AA and NA. AA was thought to have been founded in June of 1935 by Dr. Robert Bob Smith and William Bill Wilson. If you have a chance to read their story, if you don't already, it's a great story to learn about. It was during this, so they were recommended by friends to meet with each other. It was during this meeting that they realized the power of sharing with each other and then helping each other. And so the self-help philosophy of AA was born from this movement. The early founders of the meetings decided to put together a book, sort of a compilation of their stories, their successes, and their failures. And so that became the big book. The book's called the Alcoholics Anonymous, but it's often referred to as the big book. And then in 1953, a new group was founded through the AA model, and it was called Narcotics Anonymous. The quote on the board was taken directly from the Narcotics Anonymous book, which is their version of the big book. So as we follow the same path with only a single exception, our identification as addicts is all-inclusive in respect to any mood-changing, mind-altering substance. Alcoholism is too limited a term for us. Our problem is not a specific substance. It's a disease called addiction. By the way, those are my goats. Anytime I give a lecture, it's always my goal to fit some of my farm animals in there. So that's Pip and Squeak offering each other mutual support. So as I mentioned, other support groups have taken that AA self-help structure and created similar models. Bigger cities tend to have a more wide variety of meetings. So in West Virginia, we're sort of limited to the options that we have. So along with AA and NA examples would be Opiates Anonymous, Cocaine Anonymous, Rational Recovery, Women for Sobriety, SOS, which is sometimes either secular organizations for sobriety, or sometimes they'll call it Save Ourselves. Al-Anon, I know West Virginia has a handful of those meetings, and those are really vital. Those are, Al-Anon meetings are sort of the sister meetings to AA or NA, so those are the meetings that we send family members to. So for family members or friends or loved ones of people struggling with addiction, that's where we would send them to, because they really need the benefit of group support to help them deal with what they're dealing with their loved ones. So the 12 steps, I don't ever tell somebody that's working in this field that they have to memorize all the steps word by word, but I think it's really helpful to know what they are, particularly to understand the importance of some of the bigger steps in there. And so that's really the core of AA, or the 12 steps. The steps are not required for members to complete, but are simply suggestions. And so we will recommend patients, when going to meetings, we recommend them to get set up with a sponsor. And a sponsor is somebody who's been in the program any length of time and has a significant amount of sobriety under their belt, at least a year, if not more. And that relationship with their sponsor is what they would use to kind of work through those 12 steps. The 12 steps fall into 3 groups. Steps 1 to 3 help focus, they help the individual kind of focus on making the tough decision to confront their addiction, to accept that the disease that it's been affecting the individual and the individual is powerless over it. Steps 4 to 9 are what we call the change-oriented steps. So those really help them with the process of identifying, confronting, and then overcoming what has happened during the addiction. The steps are also designed to help the individual kind of process through the guilt that's often arisen for them and to help them let it go. And then steps 10 to 12 encourage the patient to continue to build on that foundation that was established. If we're looking at the stages of change model, which I think we've talked about in here before, those steps are really associated with the maintenance stage. And a lot of the steps talk about a higher power. We always want to stress to our patients the only requirement for a higher power is just that it's something greater than the person. So on occasion, that can prevent a patient from wanting to go to a meeting because they think higher power automatically has to be God, or they think it has a strong religious component, and that's not the case. So we want to kind of help them work through that. So there's pros and cons of 12-step programs. The pros are, oh, sorry, if you want to click through all of them, I don't know why I could do that. The pros are they're open to anybody that needs them. You know, there's no becoming a member of a 12-step program is available to everyone. There's nothing that's going to keep folks out of being able to be a part of those meetings. They're accessible and available everywhere, even in West Virginia, you know, while there does require some traveling to get to them. There's also online options these days, which we'll talk about in a little bit more. So they're a lot more accessible than they used to be. And in some of our rural parts of West Virginia, they have more meetings than they used to in the past. And again, with the online option, they are available everywhere. The program is free. There's no dues to pay. There's no admission fee you have to pay to get into a meeting. There's no dues you have to pay for the chapter. So there's no financial component to it. It's a flexible program in that you can work that program around your life. So maybe somebody's schedule only allows them to go to meetings in the morning. Well, chances are they're going to be able to find a way to make that work for them. Or maybe they can only go to the meetings in the evening, or maybe some weeks they can go to one meeting and some weeks they can go to more than that. It can be flexible to make it work with their life and their lifestyle. And then by definition, a self-help group is self-governing. And so that can be really comforting to folks, particularly early in recovery, to be going to a similar peer group, to folks who have been through literally what they've been through. So the cons, so we talked about the pros, the cons of 12-step program. Not everybody digs the spiritual emphasis of the group, and again, I just mentioned that can often get confused with there being a religious component to the program. So sometimes we'll make sure that people know about SMART recovery meetings and rational recovery meetings. That might be a better fit for them. While the program does have a flexible aspect to it, some people actually view the program as rigid. Our medication-assisted treatment patients run into this sometimes because they will go to, for example, NA meetings in Morgantown on occasion can sometimes have a view about MAT, and that, you know, patients using medication-assisted treatment are not technically in recovery or not technically sober. That's sort of a rigid viewpoint that meeting has. So, and that follows along with the next one about negative biases. So we want to help educate patients ahead of time that that's a potential stigma they're going to run into. And so how do they want to handle that? Who do they want to choose to share their MAT status with or not? How can they go find other meetings that are supportive of them? Some people don't like that AA meeting has a limited focus, which, you know, kind of differentiates it from other social groups. Folks are really to go there to kind of talk about their life in regards to their recovery. And it's funny, we want to encourage people to go to meetings for support, but we also want to be weary of folks relying on meetings too much. So it can become a bit of a compulsion if people feel like they have to go to meetings every single day, and if they don't, that they're automatically going to fall apart. So we want to address that. And then another side note on the con of the program, in terms of its effectiveness, it's a little hard to measure for research purposes. The meetings have such variance among them, so it's hard to kind of establish a standard on which to study. If you can. So I want to talk about the role that technology has played in the recovery field. Most of it is good, but of course with everything there has been some issues with it. So there's websites for various types of mutual support group programs online. These are places that you can locate your local community meetings and then learn about other local resources and various tools to help you in your recovery. And some self-help support groups have a presence on social media, which can also be a great way to get people involved. I'll talk about the con aspect of that in a minute. There's also several different recovery-oriented apps. Some of the bigger groups like AA, Smart Recovery, and Celebrate Recovery have their own apps, so phone apps. I know a lot of my patients use SoberTool. It's a way they keep track of their days, and then they have a lot of other resources attached to that app. And I mentioned this earlier, online meetings are a really helpful way to get our folks who are in rural parts of the state that either they don't have enough meetings near them, or they don't have the means to transportation to go to other cities, or for folks that have strict job schedules or childcare issues. Being able to attend meetings online is a great option for that. InTheRooms.com is usually what we tell patients to go to for that. So let's talk about the pros and cons of technology and recovery. The pros are it's a great way to access resources for recovery, including local resources. It's a great way to access immediate support by finding somebody online who's available to talk in that moment. And it can be a helpful way to address our loneliness. So if I'm a patient, I can use technology either to connect with local people who are in recovery and meet up with them, or I can use it to chat online with people who are going to understand what I'm going through. And those connections I make online may help me then make sober connections face-to-face in the meetings if I go to them. And these days, technology is always around. If I have my smartphone on me and I'm getting ready to face a trigger, I can pull out my phone and text my sponsor or get on one of the chat rooms and hook up with somebody who's in recovery to kind of talk through what I'm going through right in that moment. So if I'm having that trigger in the moment, I don't know most people. I mean, my cell phone's right next to me on this table. So we have this with us, for better or worse, we have this with us all the time, and that can be, I think, a helpful resource to lean on. For the cons, in this day and age, we have to admit there's a lack of emotional safety online. So how do I know that what I share online is not going to be judged by you or shared by you with somebody else? I also may be faced with people expressing hurtful or abusive comments online. Also, so much of what we do and say online lasts forever and may be used against us in some way. So I think we're all struggling with a little bit of that lack of privacy. There's definitely a culture that glorifies substance use online. So Morgantown's a good example of that. If you are on Facebook on game day here, you're going to see hundreds of pictures of people out in the parking lot outside of the football stadium / our hospital parking lot, socially drinking under a pop-up tent somewhere. And that's socially acceptable. For folks in recovery, that's hard to be faced with on a regular basis. No judgment to anybody that did that this weekend. That's fine. So it can, that starts as an initial trigger and then can lead to a little bit of that fear of missing out for patients. Constantly having technology available to us also has the potential to lead to compulsive use. So if I'm newly sober and I'm trying to deal with letting go of my compulsive using habits, I may replace it with compulsive technology use. And then, as always, for all the really helpful information out on the internet, there's also a lot of misinformation, and Dr. Google can sometimes lead us astray. And then finally, the biggest point I want to drive home is if you have not been to a 12-step meeting before, I strongly encourage you to go and to go to several. That's going to be one of the best ways that you can support your patients, because not only are you going to be able to tell them firsthand what that experience is like, you're going to be able to talk with them about what it's like to be the first, to go to a meeting for your very first time, to walk through those doors for the first time, what to expect, how you were treated. And it's just a great way to learn, really at what the heart is, what's taking place at the heart of those meetings. I teach a addictions course for the university, and one of the students' assignments is they have to attend an AA and NA meeting, and their paper's due next week. So of course they're all attending their meetings this week. And they were talking about it in class today, and 99% of the time the students are so positively overwhelmed with their experience in going to those meetings. They can't stop talking about just how supportive the groups are and how kind, that I think a lot of them go into those meetings feeling like they're going to be out of place and not welcomed. And so many of the members come up to them and say, hey, we're so glad that you're here. We're so glad that you want to learn about what takes place at these meetings. We really appreciate your support. So they love. Now, when you are looking at meetings, and you probably already figured this out, to tell your patients there's open meetings and closed meetings. So open meetings, anybody can attend. So those are the meetings my students have been going to. Closed meetings would just be for people in recovery, but they're very supportive of folks coming and learning about what's going on. And frankly, you're going to earn your patients' respect, because if you tell them to go to a meeting and you've never been to one yourself and they ask you about it, they're going to know if you're telling the truth or not. So I think it means a lot when outsiders show up because they just want to learn about the process. So that's my spiel.
Marvelous. Thank you so much. That was wonderful.
Yeah.
All right, guys. Any questions, you guys?
I wanted to bring something up. One thing that can be a bias that comes out of mutual support groups is that some patients think that if you don't have experience in recovery personally, that you're not going to be able to help them.
Mm-hmm.
And so what I say to them is that you don't have to have a knee problem to be a good knee surgeon. And so they get kind of this idea that you have to have personal experience to be valuable.
Mm-hmm. Mm-hmm. Yeah, that's so good. I've definitely heard that from patients before. Sometimes I feel like I hear that sometimes early on from them when they have their guard up, and the hope is they spend more time with us as providers and realize we're there not to judge them, but simply just to be there, to be supportive and compassionate. I think they tend to change their tune.
guys have any questions, comments?
I don't mean to be the only one talking, but here's another idea. So one of the things that I think is most valuable about mutual support meetings is that patients meet people who are in recovery who have succeeded at what they're struggling to accomplish. And so it makes it believable that they can change. And it gives them self-efficacy to see someone else succeed. Plus they get ideas from those people. But I think just knowing it's possible, it's sort of like what happened with the 4-minute mile, you know, where nobody broke the 4-minute mile. And then when people started breaking it, more and more people did. And so it's kind of like that. If it's believable, then it's easier to do.
Yeah, yeah, absolutely. That's great.
How many of you guys have been to mutual support groups? Yes, everybody that I can see at least. And what did you guys think about them? No? Okay. Beth, see you've raised a hand.
Sorry, that was an accident. Okay, well, thank you, though. We had a AA meeting, an NA meeting. I've been to most all of them, actually.
Oh, awesome. Great. That's
And
great.
there's a really good recovery community out there. It's easier to find in some areas than it is in others. But it would be great to see that grow.
Definitely.
I have
Thank you.
question about programming in the meetings. So at Northwood, we require, at least when they start, at 4 a week. Arbitrary number, but that's what we do. Some people just can't or won't do it for whatever reason. Sometimes they say it, makes them want to use more, or they're not getting anything out of it, or they have very high social anxiety, or they just don't have the transportation or the time to do it. What do you do when someone is chronically just not attending meetings, but otherwise seems to be doing okay on drug tests and everything else?
Yeah, great question. For us as a clinic, that's not really been something that we have budged on. Made some considerations over the years. So now when folks attend an individual therapy session, we will let them count. So same thing, we have the 4 meetings a week. And so if somebody attends individual therapy, they can then count that towards one of their meetings. And that's really been the only kind of concession that we made. Generally, they figure out that when we as a clinic are not really changing that, they figure out a way to make it work. They can also attend one of those online, right?
Yeah, they can go to one online meeting per week. Maybe also suggest that they attend different meetings than the ones that they're going to. Do you guys have recovery coaches, correct?
Yes. Yep.
So maybe if the patient's willing to meet with one of your recovery coaches for an hour a week, maybe let them count that as one of their recovery hours for that week.
And recovery coaches can also help with transportation to meetings, is that right?
I believe so. I guess it depends on how they have that set up.
And what do you all do 4 meetings a week also?
Yes. Yeah.
Is there any research behind that, or?
4 hours of meetings.
Yeah, I lied. I said 4 meetings, but Douglas corrected me. It's 4 hours. So for example, if they went to Celebrate Recovery,
2 meetings counted as 2 meetings.
Yeah, that would count as 2 meetings.
If they go to 2 smart recoveries a week, that would count as 3, because smart recoveries are an hour and a half. So if they go to 2, that would count as 3.
Okay.
But we only require them to go to meetings in first year, right? Because basically after once they're in a monthly group, they're not required to go to meetings. They're still encouraged to go to meetings.
Right. Yeah.
So,
and our program, the weekly and the bi-weekly, are the only ones required to go to meetings. Once they hit monthly, we just suggest it or encourage them.
yeah, because another thing is like, a lot of people, even like in monthly groups or bi-monthly groups, I ask them whether they like the meetings. And a lot of people say they do not like meetings, frankly speaking. But those people who continue to participate or run meetings, chair meetings, they do much better. They continue to have close contact with their sponsors, or they sponsor other people. Definitely, I mean, overall, the percentage of people doing better, you can see that.
Mm-hmm.
So I guess some people are really not good for meetings, because I have a patient who has chronic pain and wheelchair bound, and it's very hard for him to get out to go to meetings, and so that kind of patients, usually are not a very good candidate for co-clinic, right? For the group clinic. So I mean, I'm not sure about the availabilities in your facility. So basically, we have fellow, addiction medicine fellow, addiction psychiatry fellow follow up those patients. So sometimes we just do individual clinic, but we still see them very often. We still do like a first 90 days. We see them once a week. We still do that. Use the same kind of, we're talking about the requirement, the frequency of visits. But otherwise, and those people are really, I mean, they're really not good candidates for meetings. Yeah. Another thing is, I think a lot of people really like meetings at the beginning. When you ask them, they will say, yeah, the meetings were kind of so important. They really helped me at the beginning. But once they're into good recovery, then they have their jobs, they have family, they have relationships, they have a lot of good supportive resources. So I don't know. A lot of people just stop going to meetings, monthly group and bi-monthly groups, right?
Right.
So I don't know what's the percentage, but we do have people. You ask them whether they're still going to meetings. They say, "Well, I'm not going to meetings anymore." However, looking backwards, those meetings were really helpful at the beginning. So they know those meetings could be very helpful. Another thing is, like, I think we are human beings. We like and dislike. So a lot of times on DDU and in my co-clinic, so I ask them, you don't like those meetings because well, yes, you go to the meetings, you see people who go there because of legal reasons or different kind of reasons. They're not going to the meetings for themselves or because of themselves. They really, sometimes they're intoxicated or during the meetings, or use or sell like right after meetings. They make you feel like using. So that probably is not a good meeting for you to go. Just change to a different meeting, change to a different group. Now, I always ask them, do you like this group? So the group we are, we are sitting now, like a DDU group or like a co-clinic group. Like those, basically, almost everybody told me like same story. Yes, I like this group. Yeah. I feel this is my home group. I feel even if like we meet once a month, this group really helped me a lot. So I think it's not like they don't like meetings. Most likely, probably they don't like people in our meetings.
Yeah.
So.
Yeah. And for ones that really hem and haw on it, I remind them we're only asking them to go to 4 hours. So the rest of their week, they're welcome to try other things that work for their recovery. If it's going to church, if it's going to the gym, if it's meeting with friends to go volunteer, like nothing's, they're welcome to pick other things to be a part of their recovery along with the meetings we're going to ask them to go to.
Hey, Jeremy, for the patients who have actually read about the studies and they found out that, hey, there's no difference between the people who go to meetings versus not going to meetings, those studies actually didn't focus on who actually gets engaged in those meetings. Because what the studies show is that people who actually go to AA, only about 30% actually engage. But the ones who do engage, at 1 year, at 5-year recovery, they have a much higher chances of being recovered and not relapsing than those who don't.
Okay.
Mm-hmm. Great. Thank you again, Kate. Yeah, that was excellent.
Thank you.
All right. Do you guys have any questions about anything? Any cases, any people, any, I don't know, programmatic?
I have a question for you all. Okay, so I need some advice on this about a patient. We've had a gentleman in our group for a while who have been trying to get into rehab stay. He would come to our meetings, but he does not want to engage in groups, does not want to go in inpatient. He would make certain promises and say, and we would be like, okay, we'll give you a couple of weeks or a month to work your plan. If it doesn't work, then we need to initiate this other plan where you need a higher level of care. What do you all do about your patients who you know need a higher level of care but refusing to go, but they're so high risk for relapse, stopping Suboxone is not really an option because they've overdosed so many times?
I don't think we have a sort of picture perfect answer for that. I think for some of those folks, we have tried other means to get them involved in individual care, either with our place or other places. Some of the folks we stay in contact with during their period of time outside of our clinic in the hopes that they'll come back to us a lot sooner than later. Ultimately, if our patients don't want the treatment that we're providing them, we have to give them that respect of making that choice, even if we don't agree with their choice, which I don't like to do. I mean, I do and I don't.
I see quite a few of these kind of patients, frankly speaking. I give you one example. I just had a patient who had 22 admissions in 9 months. 22 admissions in 9 months. We're talking about not 9 months include 1 month of 28-day program, Center for Hope and Healing. So just that month saved 3 admissions, because if you do a simple calculation, that's about 3 admissions every month. So, and this person still the second time came to DDM, not second time, 22nd time came to DDU. I sent him back to Center for Hope and Healing. I also want to give you an update on another patient. If you remember, we had a patient who had 3 valve replacement, and that patient, we struggled a lot. We got her on DDU for 2 weeks, then several rounds. Finally, CT surgeons agreed to do the surgery. Then she had 3rd valve replacement. After valve replacement, she came back to DDU, stayed for 2 weeks. Then we recommended a 28-day program, and she didn't do it. Then she went back home. She got a job, and she relapsed in 3 months' time after DDU discharge. She relapsed 1 time. So she got a job, and she was living with family and with some support. But unfortunately, yesterday I got now you got email from the database, our PDNP, telling you sometimes update on this patient, whether they had another overdose. So yes, she overdosed again, and she also I went back on the record, and she was admitted to a different hospital in the same system. And also she used again, same thing like last time, she injected heroin while she was in hospital. So I feel very frustrated, frankly speaking. I think the more I do this, the more this kind of patients I've been seeing. So I guess we can never give up. That's all we can say. But I think this patient definitely is indicated for Suboxone, and there's no doubt. So if she comes back to me, I will definitely do Suboxone again. But whether she's going to comply with the treatment or whatever, I don't know. This is just one example. 22 admissions. We have quite a few.
Yeah.
Well, Dina, getting back to your question about getting someone into a higher level of care, there's a couple things about that. One is inspiring them to take care of themselves and be interested in recovery, through motivational interviewing or other motivational techniques. And then the other consideration is, what are the barriers that get in the way of accepting the appropriate treatment? So I don't know for that patient what the barriers are, but you have to kind of explore that rationally and see if there's some answers to whatever the barriers are.
Mm-hmm.
While that patient was on DDU, and she really liked the groups, and she really did well, and she was inspiring other patients as well. So I think the meetings, groups, she really actively participated. So I think at least during the period, and she did very well, and she told everybody meetings were very helpful. So peer support groups in that, at least, it depends, right?
Mm-hmm.
I guess, relapse is always a chain reaction. There are a lot of factors involved.
We've had a lot of patients like that as well, and just through, at least here, when they're resistant with us about accepting a higher level of care placement, the peer recovery coaches seem to have a better way of talking them into something like that, because a lot of them have been through it. So we've used them to pretty good effect to get that done when we couldn't do it. So
That's awesome. Does anybody else have any experience to add for Adina's question?
I have one other idea. So when I first meet a patient, I always ask them what brings them to treatment. How come they're here getting help? And that's kind of the core element of what's motivating them, or their why. And so the purpose motivates people, and then the motivation helps them kind of get their purpose realized. And so if you can, what is the reason that they're getting help in the first place? If you can get to that core element, that can often be the critical piece in motivating them to accept what the appropriate level of care is.
Awesome. Thank you, guys. Do you guys have any other questions?
I have a question. I'd like to know what exactly it means for the different clinics to refer to a higher level of care, like how you do that. I mean, I realize that different locations have more resources, but I'm curious about what is available to others.
Sure.
So I think there's all different types of higher level of care. I think the shortest definition would be increasing the patient's treatment. So if you're currently seeing them once a week, maybe you could start seeing them twice a week, 3 times a week, 28-day programs, daily check-ins. Any of that would be a higher level of care. As long as you're increasing the patient's treatment of what you're currently seeing him or her for, then that could be considered a higher level of care.
So if you're referring, you want someone to go to a 28-day treatment program, I mean, exactly who do you use? How do you make that contact?
If you have a case manager at your site, they're probably educated on those resources and how to find 28-day programs. And they should be able to contact those places to see if the patient's eligible for that facility.
Okay, so it's not like you say, I think you need a 28-day program. Here's a go here and good luck.
Yeah, if you have the opportunity to help the patient with that, so with the help of a case manager or therapist, that would be really helpful. And those folks can help figure out the resources in town. There's a great database, is it 1-800-HELP for West Virginia, that keeps track of all the...
Right, that's what, yeah, I mean, that's...
Yeah, outpatient, inpatient options, where there's located, so you can... if they have beds available, things like that.
I have a list of all these programs in West Virginia related programs. ASAM American Society of Addiction Medicine has different levels of care. Basically, most of the residential 28-day programs are kind of, they're scored. So 3.5 level. So they have usually they have 24/7 nursing care. They have therapists in-house all the time. They provide groups, activities, and meetings. Usually those places are open. People can walk in and out of the house. But the highest level usually is a kind of detox place. We're talking about an inpatient treatment place with 24/7 physician access availability. And then actually a little bit lower than 20-day program, we have intensive outpatient program. So intensive outpatient programs usually it's 9 hours a week, but it's still it's intensive, so still high level than regular outpatient. So our code clinic is just an outpatient clinic. So of course code we have different levels of care. So we create this level, we have intensive code, I-code. Basically we see patients 3 times a week. We have weekly clinic. Once they do better, then we decrease to give them more privilege. We kind of reward their good behavior, try to give them more privilege so we see them less often. So the idea is once the patient is doing better, more stable, longer into recovery, so they do not really need to come to the hospital or come to the clinic that often. So, but if they're still struggling, they still cannot stay absent from drugs or alcohol. So it totally depends. It depends on the comorbidity, because you have to look into this from like 5 different kind of perspectives, including like readiness, including we're talking about psychosocial factors, talking about psychiatric comorbidities, and all different kinds of things, different dimensions. So overall, if the patient, I guess the picture is like, if the patient's not doing well overall, you feel like the patient just continue to relapse, then probably it's the best. It's a time to refer a patient to a higher level of care. So. Yeah.
And at most facilities, then there's someone who helps coordinate that.
Yeah, in our program, we have case managers, we have discharge planners, we have a lot of people who are very familiar, who are well trained in making referrals. Yeah. I have a list.
And our
Okay.
facility, we have an intake coordinator that just does the intakes.
Yeah.
She does all the scheduling, the phone calls, and everything.
I have a list of available resources, including the residential and detox facilities, different levels of care according to ASAM level. So I can send to Galina, and you can just forward to everybody.
Absolutely, I'll send it out in the recap for today.
And a lot of patients that are dedicated to recovery, if it gets to this point, they understand, and they're usually pretty cooperative with going to a 28-day program. But you might want to prepare yourself, because you could run into the same issue that Dr. Bo is running into, where you suggest a patient is needing a 28-day program, but the patient isn't in agreement with that.
Hey, Beth, I don't want to put you on the spot. Did you mean to raise your hand? Do you want to say something?
Yes, I really did mean to raise my hand this time. Okay. What my question is, yes, I was a case manager before I got this job, so I understand how to refer someone. My question is that, since I've done this before, I also know that it takes time to get somebody in. It's not, you just can't pick up the phone and they go, great, send them over, we've got a bed ready. Mm-hmm. So with that said, I'm wondering, what do you do with them in the meantime? That's one question. The second question is, I have a patient in particular that is using THC, and it's repetitively. I mean, he's just, we need to do something. We're in a small facility. It's really hard to move him to a higher level of care, and it's really gone beyond that. So, and another question is, I know what rehab is going to take somebody with that has a THC problem.
Good point.
That I do a lot of referrals to different rehabs. Some rehab, definitely rehab. I mean, all rehab programs probably want. At least all these rehab programs I refer patients to, and they wouldn't allow patients to use THC. But if it's only THC problem, I don't know whether they're going to take the patient or not. I don't know, because in Pennsylvania,
coverage problem. I'm not sure.
Yeah.
An insurance company.
I doubt the insurance company would cover it.
Yeah.
Yes, but most people who use marijuana, they use some other drugs. So so far I haven't got, because basically on dual diagnosis unit, which is highest acute care, 4.0 and 3.9, 4.0 level of care. So I never got anybody who's only on THC. So basically, so I don't know, because insurance wouldn't cover that anyways.
Yeah.
So I doubt insurance is going to cover that.
I'm trying to remember your first question. What do we think? What do we do with patients in the meantime? So depending on what their medical status is, while we're in the process of figuring out if they need a higher level of care, if they need a higher level of care like detox or inpatient somewhere, then oftentimes we will help get them to the emergency department to get them safely and get them examined, and can even have a temporary placement there while a bed opens up for them somewhere.
Or if they're just needing a 28-day program and not the detox side of things, and say it's 4 weeks before they can get into that program, I would suggest continue seeing that patient until the day comes that they can be admitted to the test.
Okay, that's the answer I wanted.
So maybe they'll come in and
Yes.
maybe they come to your clinic once a week, but they also come and check in with one of the staff, you know, a couple more times a week,
Right.
just to be able to have that extra support and resource.
With the patient that continuously smokes THC, that might be something you want to offer them as well, because THC obviously is not part of your program, that they're allowed to continue smoking that. So you may want to suggest that we're going to give you this amount of time to stop smoking the THC, and if you don't, then we're going to have to start seeing you more often. Maybe keep them in your current group, but also
Come to the screening.
the case manager or something.
Sometimes the 20-day programs can take patient right away. So it could be same-day process. It's possible.
Cool. Beth, did that answer all your questions?
Yes, it did. I thank you all so much.
Yes, thank
You're
you.
welcome.
All right, guys, we have about 10 minutes. Any other questions? I know I saw a lot of you guys over at the Appalachian Addiction Conference. I can't remember what it was called. It doesn't matter. A couple weeks ago here in Morgantown. I hope some of you guys got to talk to a lot of the people who were there. But I did get a transportation map where they're offering free transportation for people in most of your counties. So I'm going to send that out to you guys with the recap and everything and let you look over it. They let you schedule appointments, but they'll also take like on-demand calls to go pick up a patient and drop them off.
That's cool.
Yeah, that's great. Great. Anything else? All right. Everybody have a wonderful day, week, month. Happy Halloween.
Happy Halloween.
And we'll see you guys again on the 11th.
I got
Thank you.
Bye-bye.